Sneaky. No, that's good. Thank you.
All right, we are live now.
Thank you. And Andrea, I mean, before we start the meeting, if you would resend the link out to Dr. White
Okay.
For the meeting.
Okay.
For some reason, she doesn't have that.
Okay.
Okay. So I know, gosh, I'm sure other people, I'm hoping, will join us, but are we, we're live, but we have 1 minute. Should we wait a little bit? Because I know Dr. Williams will be on as well. You see her?
Let me see here. Let me send this to Dr. White. Let's see. No, Dr. Williams is not on yet.
She said classes started this week, so sure she's joining.
Okay.
Like some more people.
We've got Mark Johnson on, Dr. Boateng, Stephen. Welcome to all of you all. Councilmember Plomin is now on.
All right, so maybe
there she is. She's coming.
I didn't want to start without her.
I saw her popping in.
Okay. Hey, Mark.
Hello.
There she
Can you hear me?
There she is. Yes, we can. Hey, Mark.
Okay.
Hey, Dr. Williams. Of course, her sound's coming on. Councilman Plomin, who was there and left.
I think she just turned her video off, and camera off, but she's still there.
She's still
there.
Hey,
everybody.
Hey.
Hi, Dr. Williams.
How are you guys doing?
Good.
Partner in crime. I didn't want to start without you. So it looks like, hey, there's Councilman Plomin again. There you are.
There she is.
Okay.
We've got our quorum at least if you want to move ahead.
We probably should since, here comes Vivian. Let's let her.
Okay.
And I know Dr. White was having some problems.
Okay. Oh, Vivian's on an island today. She's on the beach.
I'm jealous.
I know, right? All right.
All right.
So let's get started since it's 2 minutes after our designated time, and hopefully, and it looks like Dr. White, did she respond?
Let me make sure she got it. Oh, yeah. I sent her the meeting ID and passcode. She asked for the link. I'm sorry. Let me send her the link.
Okay. Yeah, I'm sorry. Maybe I misstated that because she did ask for the link. I don't know what I said.
Hi, Mara. How are you?
Good. How are you?
Hugs. How you doing?
I'm well. How about you?
I'm doing pretty good.
Good.
Yeah, we're glad to have Dr. Chambers in person, virtually in person. All right, you all, we probably should get started then. And hopefully Dr. White can, I don't see anybody else popping up. Do you, Andrea?
I do not. And I just sent the link to Dr. White.
I'll be on the lookout for her and I'll let her in when she comes in.
Thank you, Quinn.
Thanks, Quinn. All right, team. we'll get started then, and we'll do what we always do, right? My lovely opening statement from the council. At any rate, due to the COVID-19 pandemic and state of emergency, this meeting is being held via live video teleconference pursuant to 2020 Senate Bill 150 and in accordance to KRS 61.826, because it's not feasible to offer a primary physical location for the meeting. So there we go. So welcome everyone. Now we have Dr. White. We can get started. Okay, we have everybody, and I'm not sure about, okay, there's Stephen. All right. So welcome everyone. And we really appreciate Dr. Williams and I, the comments. Some of you have already sent some things in to us electronically, so we greatly appreciate that. So we'll get to business. So before we do that, is there any feedback about the minutes from 7/29? And if there's no feedback, may I have a motion from someone to accept those as nicely printed by Andrea?
So moved.
Okay,
Second.
you get that, Andrea? Because I saw Councilman Plum. Okay, thank you very much. So if everyone would denote by aye for your approval of the minutes, to say aye or raise your hand.
Hi.
Okay.
Aye.
Opposed, nay? All right, great. We have it. We have it. We have it. At this time, I don't have any commission updates other than, thank you, Dr. Butang. He always does the, yeah. Any updates outside of our original timeframes, team? You know, we still had the additional days, right, to be extended through the end of next month as needed to turn in our final report to the co-chairs for the commission. And there hasn't been anything different stated from that time frame. Anything, Andrea or Dr. Williams, that I'm missing out or missing? Hey, there's Timothy.
No.
Oh,
Yeah, I mean, I think we're good. The other thing, of course, what we'll do, and Dr. Williams and I will lead you through the discussion of the report that we sent out, yes, Monday. And so really what we want to do is use this time to go through those questions that we sent out to you. And actually, thank you, Andrea sent out to you. So we want to look at the top 3 recommendations, and we want to kind of go through those questions, and obviously any other comments, because we may have missed some things. We tried to think about all the documents we had reviewed, as well as your comments during the subcommittee meetings, because that was obviously very important, because this has to be a reflection of our work and our time of sharing together. So we were very cognizant of that as we developed the report. So we would really just like to start, and I'll, Dr. Williams, you might have some overarching comments or whatever that you'd like to make at this time.
oh no. Really, I'd like for us to focus on the questions that we sent out. But before we did that, I first wanted to know, just from looking at the draft that we sent to you all, what we were trying to do is just capture the essence of all of those conversations that we've had over the last period of time. And I want to know from you all, from reading it, did it feel like it captured the main part of what we wanted to, of what we shared over these calls?
I see some nods.
I think it did.
It felt like it did. Good. We tried very hard. We poured through the minutes and really try to capture all of your suggestions and experiences.
This is Mark, and I think there's a couple of things that probably should be added if it's not too late.
It is not too late, definitely no. And that was my very next question. So what?
Okay.
What?
No,
Jump right in.
I was looking at all of the recommendations, and for partnerships, I was thinking that AIDS volunteers or AVOL Kentucky, because they also have a mobile and they do HIV, hepatitis C, and all that testing throughout Lexington and Central Kentucky. The health department also has a mobile that could be used for those type things. And as all of you know, HIV is still disproportionately affecting African American and Latino communities. So we need to be on board with that.
Yes.
Excellent. Thank you.
Thank you so much. And Mark, if you would please, because we want to make sure that we capture the thoughts of everyone on this subcommittee, please give us that written. So we want you to like, where would that fit in our final document?
I think under community partners, where you're talking about necessary partnerships.
Yeah.
Okay. And I was also looking at the Black Church Coalition. I don't see that anywhere. When you talk about faith-based and all that, that's another group where people come together monthly and you're able to dispense information or distribute information through that group. And that'd be another partner.
And the beauty of the Black Church Coalition is that it has a reach that's broader than the Black Church. So membership, it's very broad.
Right. And that's just,
I apologize. I haven't looked at the list in a while. Is the Kentucky Council of Churches on there?
Nope.
It needs to be on there too, because Pastor Gillette at East Texas Christian is president of that organization right here in Lexington. So he's doing a lot of work through the Kentucky Council of Churches.
And Vivian, if you
what Gillette?
Would you email us that as well, just so that we have?
Yeah, I will.
Okay.
I will.
Great. Because Mark, both of you've given some great insights. Yeah.
Thank you. I have 2 more.
Oh, that's great.
What?
Jump right in, Mark.
Under the food bank,
yes,
food distribution, the Pride Community Service Organization, PCSO, that does a lot of work for LGBTQ and allies. They also have a food bank, and they do that once a week. So I think for the community, they need to know that, and it's open to everybody, not just a specific population.
Excellent.
And then lastly, I think it was also on partnerships. We were looking at where you have BMW and all these different organizations. We do have 2 African-American LGBTQ groups in Lexington. We have Bluegrass Black Pride Incorporated and Kentucky Black Pride. And that's a population that's often on the other side and left out. So I want to make sure that if people need, these are some resources that are included.
And so would that go on the partnerships, Mark, or?
Wherever BMW, but they could be a partnership as well. Let's see.
BMW, my remembrance of that was under pipeline programs.
Pipeline.
Right. It was under cultural competence. Number 5, recommendation number 5.
Okay.
So maybe that one we could fit that either under the community. We'll figure it out. We'll put it in there as long as it's in there.
Yeah.
So, because I think those are very important partnerships, and it could even be with under the Community Health Improvement Plan, although I know that's looking at our data, but that's where we also talked about the Community Advisory Board. And I just think that those are all good advisees. So we could
right
under that partnership and slip it under that section of the report.
All right. Now, before my time is up, this is the last one. I kind of fibbed and said I only had 2 more, but this is the last one. I work for the Kentucky Department for Public Health, and we have funding opportunities for churches and other organizations where they could get several $100s. And with that, we can have informationals. Like we usually do it for HIV and AIDS and STIs and Hep C. So if a church or a group of churches or a neighborhood wanted to do something for like Black HIV AIDS Awareness Day or a National Church a Day of Prayer for HIV and AIDS, they could always submit a mini application and they could get several $100s to put this on.
Wow, that's good to know. Money is always important in any discussion.
So I hope you're typing, Mark.
I will be typing.
Yeah, he's talking all fast and we're trying to write it down.
Oh, I'm sorry. I'll get that to you in an email.
Okay. Thank you.
You're welcome.
Keep them coming. Kathy, I see your hand.
Sorry.
Yes, can you hear me?
Yes.
Just a side note as to what was just shared about funds. Each council member also have what we call NDF funds, and we can take requests. And during the course of the year, we pass. It's kind of like a sign-up sheet for different needs, and any council member can put whatever amount of money they want, whether it be a couple $100s or whatever. So along this process, just know that that exists, and you could access it. I just thought I'd remind you all when that was brought up.
Oh, no, that was news to me.
Mhm.
So how can those funds be used? In any way?
Yeah, oh yeah, in terms of
Okay.
education or an activity, an event, materials, marketing materials.
And you request those through your council?
Yes, you could contact me, and then I could go ahead and write it up, and then it would be passed around at a council meeting.
Okay, gotcha.
Okay.
Timothy.
Hi, everyone. One, I think the recommendations report looks great. I have a suggestion for recommendation number 2 under necessary partnerships and structure.
Mhm.
I think that we should add in here some of the local nonprofit organizations, a nonprofit sort of network, because we know that as community health workers go out and they're building relationships, assessing needs, undoubtedly that won't be the only need that's uncovered. Those are specifically health related. And I think having that connection with nonprofits and being able to have referrals on deck for a variety of needs will sort of just speed the process of getting people to the necessary services, as
Right.
well as being able to leverage 211. Again, it's a 24-hour day, 7 days a week, both telephonic and also internet-based directory helpline, not just a directory, but actual helpline where if you dial 211, someone's on the phone waiting for your call 24 hours a day, 7 days a week to connect you. And I think that could be a valuable resource to these community health workers.
On that same line, and thank you for bringing up 211. We talked about dissemination of where healthcare providers were, healthcare providers of color specifically. And we talked about a directory of them. I wonder, would 211 be a good place to house a document such as that, or information such as
Or
that?
another place to house it, right? Maybe not
Yeah.
the goal.
Right, it can be in multiple places.
Yeah.
I don't see why not.
One of the places, yeah.
Mhm.
It's great.
So you're sending us in writing to Timothy?
Sure, I'll be happy to send both of those points.
Thank you.
We were also talking about 211 as well in terms of, is there any kind of reports or information that can be pulled from that based on zip code and the type of requests people are making? Because we
Absolutely.
were trying to discern whether that would also be kind of like a pulse check or checkpoint about what's happening, and it's kind of real time.
Yep.
To kind of, okay.
All of the above. Yep.
Okay. Yep. Great. Great.
So Timothy, in the past, how has those data been used? Because what we'd like to see is that as we're getting data, that data drives where resources are needed. How's the data used now?
That's how we're using it to figure out in grant making, where do we want to deploy additional resources, and also to help educate other regional funders on where to direct their dollars based on the need.
Okay. That's good.
Perfect.
Yeah, that's good to know. Kathy?
It's me again. Back in my United Way days, we started 211. And one of the things that we found, and Timothy just alluded to that, is that we could see where the gaps were. And not only could we see where it told us as United Way, here's what we ought to be working on because there's this void. As each call is tracked, as Timothy said. And so you kind of get to look at the whole picture of the community and say, well, we're not meeting that need. So it could be a great resource.
Absolutely.
Like that. We talked about that. So that's good. We just had, so how do you access those reports though, and that information? Who does that, and how frequently? And
so I sent out in the beginning, I think, of our committee a link where you could actually go and see 211 reports. That information is, you can run reports based on zip codes.
Out of that link? Okay. And I apologize.
If I need to send it again, I'm happy to do that.
Oh no, we have it.
We port through so much.
Yeah.
I can only imagine.
I mean,
But that does sound familiar.
Thank you.
You're welcome.
Welcome, Michael. Rabbi Lipkin, those are, yeah,
Okay, keep it coming, guys.
this is good stuff.
We're going to keep picking your brains as long as we have you.
And I'm presuming, Dr. Williams and I also talked about, I mean, when we were looking at these questions to pose to the team, we wanted to make sure, and I believe you all have already answered this, so I'm just going directly to the question. Do you really feel like we've looked at all the barriers and we've done our job in terms of what we developed in the report and the result of that and the barriers you feel that exist current day that we really needed to address? Do you feel comfortable with that? And I believe I heard you say it's just a different way of asking the question, but I think that's what Dr. Williams asked at the beginning, but we've had a few other people join. So we want to make sure that we've been all inclusive with our lens and the people we want to serve through this report, right? And these actions.
I think so. I sent in my few little paltry suggestions. One thing that kind of came in over and over again was the stigma, right? And I really like this idea of a community mental health worker. But the piece that I was unclear on is, how are we going to protect patient information? Because sometimes people are less than likely to disclose to people if they feel like it's going to get out in the neighborhood. And I don't want to over assume that because someone, shares phenotypic characteristics that they'll just automatically utilize those services. So, how could, and it can be done, I'm sure, but how can we express, in the document that we've taken that into consideration?
That's a very important consideration. And, everything we are recommending will have to be refined. But our expectation, or one thing we would like, is that the community health worker is a true, real position that's affiliated with the healthcare system. So that individual would be expected to have the same level of HIPAA that all of us are expected to follow.
Yeah, because we had that discussion after we saw your questions.
Yeah, very good.
And it was very insightful. I agree with that. But if we can get that model to where these individuals are linked to facilities, those facilities have guidelines for every employee and even volunteers. I mean, anybody you have that you're having in that capacity is required to sign off on HIPAA and PHI and all those things as a team member, part of the workforce.
I emailed you all my recommendations and my suggestions. You don't want me to go over them, do you?
Oh, no, that's fine. We just wanted to get them in one form or the other. And written form is the best. Thank you.
Yeah, they were very insightful. They were good. I mean, we need to expand our scope in terms of College of Health Sciences and some of the places where we're going to partner as far as the university, that we include all of our professional health colleges. So, I mean, there were some other things, Dr. White, you had, but they were all really good.
So what, go ahead, Dr. Talbot, with the next.
Well, no, I mean, go ahead, Dr. Williams, because
I was just thinking about, I know how it is when I get a document and start reading through it, that item number 1 grabs my attention and holds it. So as we started thinking about how to prioritize these things, they're all so super important. What order? If we had to name our top 3 that we would feel that our work has been done not in vain, if we achieve these 3 things, what would those 3 things be?
Can you not screen share this document that we're referring to? just because I can't pull mine up at the same time I'm looking at you on my laptop.
Oh,
Can someone, can you or Dr. Talbert or Dr. Williams
Yeah.
screen share this?
I don't
Or
have
Andrea,
it.
can you screen
Yeah,
share?
I don't have it open.
Do you want the recommendation screen shared? Okay.
Right, she's asking us if we had to prioritize, how would we prioritize? But it's, I'm a visual, it would help me if I could see it.
Mhm.
And that way,
So do you have, okay, Andrea, you have it?
Yes, I'll pull it up.
Because I was going to say,
Sorry, take me a minute.
okay, of course. Timothy,
I see you, Timothy.
I know, right? Being an overachiever here.
Mhm.
So if I'm sorry, am I interrupting? Oh,
No, you're not interrupting.
I just heard something going on in the background. Well, in looking over the document, if I were to rank the top 3 things that I see on, I would say that the number 2 recommendation, the community health worker, and these, I guess, are not in necessarily any particular order. And then the number 3 recommendation for the food, and then the number 5 recommendation for the cultural competency would be probably the 3 most important that I would see.
That's again 2, 3, and 5.
Yep.
It's the same thing that Timothy said.
Great minds think alike.
I did not hear that, but I'm glad we do.
So are you still looking for it, Andrea? Because I know, or how are we doing that? For the screen share? No?
Yes, I'm sorry. I pulled up a different thing that was it was something different. I'm sorry.
Oh, no, that's okay. I just
still-
didn't know where we were with that.
I think someone was starting to say something before Andrea was responding. Was somebody starting to make a comment?
25.
This is Mark. 2, 4, and 5 for me.
Your Mark, remind us what 4 was, the topic.
4 was transportation.
Okay.
Andrea, if you can't pull it up, I pulled it up on my phone. Don't worry about it.
Okay.
I'm sorry. I've just got to I have like 20 emails between then and now.
No.
Yeah, so that's
I'm
the
so
same.
sorry.
Well, echoes number 4.
Okay, sent. I'm so sorry. Dr. Talbert, if you have it, can you email it to me and I'll post it up once you send it. I just can't find that particular one right now for some reason.
When I think through them, I would probably prioritize 2, 3, and 4. And the reason why I would prioritize those 3 is they feel like they have more immediate actionability to them,
Gotcha.
where 1 and 5 are critically important, but they feel like a much longer horizon to have the kind of impact that we've all talked about during our meetings.
Yeah.
It's hard for me to prioritize any one of the 5 over the other 4 because they're all that important. That's the lens that I use for saying 2, 3, and 4. They just feel a little bit more immediate in their actionability.
Yeah.
I would also suggest in number 3, we maybe reinforce somewhere in there the importance of community engagement in establishing neighborhood routes or whatever it ultimately looks like. Mr. Overstreet made some really important points about that a couple of meetings ago, and I think that one particularly needs community engagement in the right way to make sure that it doesn't feel like something that is being done to the community, that it's more about the community engaging in the results. And I will share with everyone that, since some of that is, right in our wheelhouse, I've already had a whole bunch of really good conversations up to and including some potential funders that would be interested in supporting that kind of a program. I do think it very much needs to be a private-public partnership. That's a community-based activation of private-public partnership. But I'm aware of some funders that would be all over it. If endorsed by the commission and supported by the mayor, I could see myself being involved in that committee pretty quickly.
Thank you.
So,
Yep.
Michael, you going to strengthen that section for us in your writing, please?
I'm sorry?
Can you strengthen that section for us with the comments you just made?
Yeah, I will give it my best shot. Last 2 weeks have been interesting for me, to say the least. Not as devastating as some of the stuff that Timothy's had to deal with, but interesting nonetheless.
We
I'll
appreciate
give it a shot tonight if I can.
Okay, we appreciate that.
Yep.
Yeah. Okay, can you all, let's see, where are we? Yeah.
For me, it would be 2 and 3, and I'm in between 4 and 5. If 5 is done well and the curriculum is evidence-based and it's appropriate for the different audiences that we have, then I would say 5. But if it's not, and if it's more of that sort of surface level training, I'm against that. And I think that's what we've been doing.
Right.
We need to change things up.
And there was discussion in an earlier meeting about a curriculum of choice.
Yes, the National Coalition Building Institute.
Thanks for that, Dr. White.
Well, for certain, number 2.
Yes. Common.
Yeah,
No
everyone has selected number 2.
Well, and it's an existing program that we can expand on. So I think it, to Michael's point, we could get some early wins from that. And I think Dr. White has pointed out the fact that we would need to look at volume of those individuals, but it's something that is in place.
Yeah.
So some of the comments, Dr. Boutang had mentioned, of course, you all see that, transportation being very important, which is number 4. Right? And then Vivian 2, 3, and 5, and she believes 4 is running very close behind correctly. So. And it looks like 3, at least is a mode, a common, another one. I mean, 2, 3, probably, have some common ground on or support.
Yep. And
then tossing 4 and 5, depending on how it's done. Which we want them all to be done well. And right. So.
I think when we look at number 4, the transportation, let me find it. I'm sorry. What I would like to see on there is, along with the expansion of the Wheels program, I would like to see more efficiency in it as well. Just not expanding it and it being just as inefficient as it is now. Like, let's expand it and make it more efficient than it is at this point.
Great point.
Yes, Stephen, can you guys speak a little bit about what those inefficiencies are?
So one of those inefficiencies was that you are at a hospital and you have a doctor's appointment and you order a wheels bus. If there's someone who's already in the waiting area waiting on a wheels bus that they've ordered previous to you, you have to wait on them to be picked up and dropped off, and then you're picked up later, instead of you being able to get on the same wheels bus that comes at exactly the same time that you're ready to go. You may have to wait another hour after someone else has ordered one. So why can't that just be added? I mean, those are simple things to add to a route. It may make the route home a little longer, but you're not in a waiting room waiting on a bus to get there for an hour.
Right.
One of those. That's one of the inefficiencies. And then how the routes don't necessarily go to all the same areas, but I think that is addressed in the document.
Okay. Thank you.
So,
Next question,
Yeah.
Dr. Talbot.
oh, let me pull those up. Look, I'm looking at people. So let's see. So I would say the next question that we really haven't talked about, we wanted to make sure with you all how you felt about any additional suggestions or additional recommendations to support the sustainability of the plan and moving it forward. I mean, you know, we oversight, monitoring. I mean, do you feel like there are any other things we need to recommend with the report to make sure that this work remains in front of the mayor, some accountability components? I mean, what are your thoughts in that way? Oh, great.
Right. That was good. I was thinking just that thing. I don't see us talking about how there's any checks and balances for this. There's, who's going to make sure some of this moves forward. That can either be done through a commission or an advisory group or a person or coordinate something or some group or somebody. And usually that's not done through a volunteer position, but through a paid position. So my question is, committing resources with funds. Are you thinking of, is the mayor thinking about where additional dollars could either be drawn from, dedicated to support doing some of these things and coordinating some of these things and providing oversight? So I don't know. That's and then what do we see? What does sustainability mean to this group, I guess, is another question I have. Because what I think might be sustainability and what I see as something being sustained over time may be different to what some of the rest of us are thinking about. So, do these 3 recommendations or 4 recommendations, how do they grow into additional things? I mean, where's the growth, I guess is what I'm saying, because we talked about a lot of things and a lot of good things on the list, and I would hate to see them lost. So how do we kind of tier them or phase them? Or we had talked about doing that. I think that was one meeting we talked about having a more of a phased approach or a tier. This is our first group. This is the first phase or first tier of what we see as to be immediate need. And then how do we prioritize from moving forward? So those are some of the questions I have.
I think Vivian, I'm sorry. I think Vivian, part of the overview would be with the recommendation 1 that we didn't really vote on because it talks about the community health improvement plan and bringing together that group to kind of make sure and hold us accountable. So that would cover some of it, definitely not all of it, but I think that's one that would help out.
Yeah, and I talked to Christy about that, Mark, and I'm not sure. I mean, it's a piece, but not to me, the overall driver to me of this. But I understand what you're saying, but I think that's a small part.
Right.
Important,
it's a small part.
Not...
Right. And there was a group that you worked with, NOAA Navigating Obstacles in African American Health or the African American Health Network, we can bring those groups back and they could be paid or whatever and be used as the oversight.
Okay, Mark. Type
Yeah, Noah would love to be brought back.
Okay.
Yeah, Noah would love to be brought back.
So was that something, Vivian and Mark, outside of the CHIP process? Or was it?
Yes.
Okay.
I think they could serve as the CHIP.
Okay. Wow.
So,
go ahead.
Go ahead.
So when you say bring those back, where are they? Are they just defunct now, or are they doing other things? How easy is that?
The African.
So,
well, the African American Health Network.
Go ahead, Mark.
When I left the health department, the African American Health Network left when I left the health department. We talked about that a little while ago, and so we could always bring that back. Vivian, Noah.
NOAA was a 501c3 navigating obstacles in African American health that is just inactive. We don't have a president, we don't have a chair, but it's still a recognized entity. We just haven't been doing anything. So
it strikes me that the risk that we talked about 2 or 3 meetings ago, where you have wonderful ideas and wonderful intentions and actions, and a champion who supports them, and then champion moves on to another job, and the wonderful ideas and actions are lost.
Right.
So if it strikes me that if we're going to talk about sustainability in our recommendations, we need to say, here's what you don't want to do, because doing the same thing over and over again and expecting a different result, we all know what that's a definition of, right?
Right.
So part of this might not be necessarily delivering the answer. Part of this might be, here's the don't do. And let's figure out what the to do is, knowing what the don't do is, right?
Right.
So if it's about a single champion, we've already proven that that works for a while, but it's not sustainable. Don't go down that path again. It's got to be institutionalized in our processes. It's got to be institutionalized.
right.
Or it will fail.
I like
as soon
the
as
idea of building an
champions go away.
infrastructure for that.
Yeah, it's
Right.
got to be
Yeah,
institutionalized.
I think there should be an infrastructure.
Mm-hmm.
I agree with Mike.
Any other? And when you say that, Vivian or Mike, any other thoughts on what that would look like? I mean, we've talked a little bit about NOAA. We've talked about, and I think Mark pointed out the fact, I know Dr. Williams and I, when we looked at this and developed the whole CHIP piece, what, Vivian, and you're very familiar with this, I guess, what were some of those pitfalls that, to Mike's point, we don't want to recreate in that process that didn't work so well, that we might want to reinforce or not reinforce, but talk about alternatives to make that a better workflow?
So I say again, because I'm not sure what you're asking me, Dr. Talbert. Say again.
About sustainability and your operational definition of sustainability and building an infrastructure. What are some of the, I guess, must-haves of that? Maybe more simply asked, for this infrastructure.
So when I think of infrastructure, something that makes sure that this hangs around is either a unit or some type of section or division, or however whatever is in her executive cabinet. And I think it ought to be at the executive level. And by that, I mean where it's not buried 5 layers down within, and we know how that is. It's got to go through 5 channels and 6 other people and 5 signatures and 2 okays and a thumbs up before something is acted upon. So I think that infrastructure ought to be within her executive cabinet. It ought to be a unit that has at least 4 people to be a functioning unit that has some of that. If one person leaves, the historical memory leaves with that person. It ought to be, it ought to be arranged and set up so where if that person happens to move on, the integrity of the program stays, the information stays. That's what I'm thinking of, something that's really intentional, something that's really built in, thought about, something that this is how this is going to now become a part of my cabinet. And I'm very serious about this, and they have my ear. And that to me shows the community that you are actually walking the walk that you're talking about. If I see the intentionality of that, if I can see that those positions created or that section created, that speaks to me in a different way than us just sending in recommendations and not knowing where they're going to fall. And she reads those, and we, all good intention that we've done this work, but we really don't see the fruit of our labor. And to me, that would really be seeing a tangible fruit of our labor. So,
Yeah.
I don't know. Other people.
I agree with Vivian.
I'll echo that. It's about organization as opposed to about individuals. So some of the food insecurity stuff that we've talked about, there are 200 food banks across the country. There are 60,000 food pantry and meal programs across the country that are working to end food insecurity. So if we make, that third recommendation can be part of an institutional effort to make a change as opposed to an individual making a change. So I think what Vivian just described from a governmental standpoint, it's not about an individual in government, it's about a department in government that's bigger than, more than one person, right? And as soon as you make it about an institution that's doing work, that work will live beyond any one individual in the institution because it's been sustained within the institution.
I think on an organizational level, though, right? I mean, when we talk about regulation and creating systems, there's a couple of things we need to do. We need to include the consumer, which I think you all have wonderfully done with this community piece. We also need to empower the consumer, which I think has kind of been broached. But what I think the key element is missing, you also have to incentivize on some level the provider to do what it is you're asking them to do. Because without that, I mean, you can regulate, sure, but if there's no incentive from the part of the actual provider, there's no way that that's going to reinforce the system. And I think the private sector does that so much better than governmental entities because they find out what actually works, what, let's be honest, what makes money. And if there is a way to push resources in a way that, and I'll say it again, incentivizes the actual provider, then I think that'll push us in the right direction.
Good point, Dr. Botang.
Yes.
Well, thank you. Now, what I didn't say is how to do it. So
I know, and see, that was going to be my follow-up question. Should we be targeting any, when we say providers, because that's very wide and broad, right? Are we talking specifically? What are your thoughts when you say that?
Well, I think like a couple sessions ago, a couple meetings ago, a medical doctor discussed some people, some providers just want to be more culturally competent and others really don't think it's a big deal. Well, the reason they don't think it's a big deal is because they're not graded on it. It's not something that's publicly available, which I think, again, we've touched on, but it also doesn't, there was nothing to say that, well, there's an incentive for actually being more culturally competent. There's an incentive for seeing individuals that, are more less inclined to receive service. So we can be talking about mental health, we can talk about medical, social worker, et cetera. And I'm not saying, it gets into kind of another argument. Well, are we talking about subsidized? Well, no, that's not what I'm saying. I'm saying some tangible incentive, whether it be a tax incentive or something, if an entity can prove that they're moving in the right direction to be more inclusive in terms of their services.
Gotcha.
Yeah.
So it's interesting to hear you say tax incentive, because one of the first things that popped into my head, Dr. Talbert, when you asked that question, was, can the Lexington Fayette Urban County government offer a tax rebate on income taxes that are paid by entities as part of the Fayette County urban, as part of the urban government income tax process. Now, those tend to be individuals, not businesses, right? So I don't know exactly how all of that works. The second thing that popped into my head, is it possible to create some kind of an ESR-like granting process specifically for this kind of work that gets to the incentivizing of participation in recommendations and in driving those recommendations to completion? And that could be funded by the $25 million CARES Act pool that's available to the city. Everybody's clamoring for that money. So we would just be one of, probably 200 or 300 others that are asking for a slice of that pie. But there could be some really interesting conversation around how do you fund to then provide the incentive that drives the result.
Yeah, I love that.
I do too.
Yeah, some really good conversation. Yeah.
Yeah, there is a long line for the CARES money, I'm told. So yeah,
Oh yeah, it's a real long line.
Yes.
it's a long line. Not a bad idea.
Right.
Dr. Chambers, what are your thoughts? Oh, you're muted.
There you go.
Well, speaking along the remarks about incentives, speaking as a physician, and I think one of the other sessions we discussed the lack of African American people of color in the workforce. Could there be a tax incentive there as far as, we want our medical schools and hospitals to reflect the population that they serve, and we know that we're far below that. And so is there an incentive, or can there be an incentive offered, as we try to make progress to increase those numbers of African American physicians, not just at UK, but throughout Lexington?
Good point.
All those, yeah. And Dr. Chambers, when you think about that, and maybe I'm being too detailed, but do we look at that per facility, since you were saying, obviously not just looking at UK, but let's just say, let's say UK could get more of those people of color than CB and St. Joe. We're not looking at that as a collective pool, because when we look at that, we're looking at the Lexington share, which is about 15% for African Americans. And so do we share that share? Or do we have points of goals for each facility? I mean, because we're not all gonna probably, because we're gonna all be buying for some of the same people.
Exactly. I just think we want to see that progress is being made. And so what can we measure that?
Yeah.
We can look at that raw data to see what percentage of your staff, particularly physicians, physician assistants, are African Americans, Hispanic, people of color. And each year, how is that? Are we making progress, or are we still at that same, 5% or so? So just a way to be able to measure that and possibly incentivize that.
Right. Okay.
And Dr. Talbot, I'm still hoping to get that information that the Kentucky Medical Licensure Board promised me, and AHEC, as far as how many physicians are in the Lexington Fayette County area by specialty, race, ethnicity, and gender, and their location within the city. So I'm still trying to get that information. They did promise it to me. I was hoping to have it by this meeting, but it didn't come. So I'll remind them that they owe me that. So that'll be something that we can have too. So
I like that. That's great. Thank you.
I really like having metrics.
So did Rabbi, I don't see him anymore, so he must not be on. He was the only one we hadn't heard.
Who are you looking for?
Rabbi.
Yeah, Rabbi. I don't think so. I don't see him.
I think he jumped off. Yeah.
Yeah.
But Dr. Chambers brought up a good point. I don't have that. I can get that information for PAs in the state. I can get that from, I know the director of the nursing,
Yes.
director of the board of nursing here in the state, but is that additional information that you think you would need for healthcare providers? Or are we strictly looking at physicians?
Both.
Providers.
All. Yes. Yes.
Yeah, providers.
So you're
Yes.
talking about independent providers, so not nursing?
Nurse-
I don't think it hurts. Sorry.
Practitioners, PAs, physicians, all of the above.
Okay, I
Yes.
just didn't know if you wanted.
Psychologists.
Okay.
Yes.
I believe
Well, Dr. Boateng will get that one. I don't have, he can do the psychologist one. I'll leave that one for him.
We'll make a note to
I'll try
ask
to do
him
the
of that.
providers. Right.
so. Go ahead.
Okay, we have 6 minutes, Dr. Talbert.
Yeah, and I think we've really gone through all of our questions we had posed to you all for this meeting. And I would just ask, would there be any other things that we need to consider? Okay, she took those down. I was like, wait a minute, you can look at the questions. But I believe we've really done a pretty good look at those, and you all have been very good to add some really fabulous comments and things for us to consider and place in the report. I really especially like the infrastructure stuff, you know, and I just think we have a lot of good stuff here and something to think about. And the fact that we also might want to thank Dr. Williams and team about the phased approach of the tiering. And it does seem that at least we have a lot of support amongst the team for number 2 and 3, and 4 and 5 both are split. But in my opinion, and it's certainly not about me, but I'm going to just comment on those. When we look at number 5, I do believe that we have some other work to do to make that and do that right. And to Dr. White's point, I think we really should look at how we approach that from a standard of an overarching standard.
Yes.
And also I think, and I don't know, somebody might correct me on this, that one would be a heavier lift because of the mayor's limited scope with how we would impact providers. I'm just saying across the spectrum. I just think that one is going to be a harder nut to crack, and thus would be further out. I would just say it's important. I think it's as important. I think it's very important, but I'm just wondering what her scope would be to enforce some of those things from a city perspective. And I don't know the answer to that.
However, she can set the standard.
Yes.
With our recommendation is that it starts there.
Yes, absolutely.
And Dr. Talbert, with your position, and Dr. Williams, your position, Dr. Vivian, with your position with the state health department, I think that gives it a lot more teeth.
Yeah.
Yeah. I think it's great.
Yeah.
I love them all. And I think obviously all of them will stay. And you know, Vivian's
I'll just share one thing about that if I could. I'm part of a new group that's formed with the Kentucky Pediatric Association, Kentucky Primary Care Association, University of Louisville, and FQHC, looking at how they can do cultural competency training within their entities. And they're talking now about how to do this with their providers. So I think the time is now to kind of, you know, I agree with Dr. White, we need to do it right. But I think now is the time to continue that conversation in some way. So we can make sure that we don't get lost as other people are moving forward. We want to see what's happening, and we kind of want to be there at the table too if we can. And to my knowledge, on that last call, no one from UK was on the call. So, which I thought was interesting. It could have just been they missed the meeting, but you know, I didn't see a name I recognize, but that's a group that's forming, that's meeting. They have a pipeline program with Kentucky State University trying to make sure that the students that come through the university really have an opportunity to excel at UK within their health professional school. So there's a lot of conversation now around it, is what I'm saying. So
Yeah.
I'll share more when I can. We've just had the first meeting, but people are actually talking about cultural competency in a different way, more than I've ever heard them talk about it in the years that I've been working. So I think now is the time to kind of push that on our agenda as well. So just want to put that out there that, some work is being done.
And Vivian, if you don't mind, could you just send to me everything you just said and what that is so that I can do some research on this end? I mean, seriously, to see who's connected and why we weren't at the table, because I'm with you. I don't want to miss any windows of opportunity. And to Dr. White's point, if we're not leading in that cause with the footprint that we have here, shameful, shame on us. Yes. So please send me that information and I can reach out to colleagues. Dr. Chambers can help me too.
Mm-hmm.
Yeah.
That's right.
Well, Dr. Williams, anything to kind of close us out?
Nothing other than to say that it has been awesome working with you guys. I say all the time on our meetings that we have the best subcommittee group amongst all of the 5. And we certainly could not have done this without you. You all live this work every day. And the recommendations are so rich because of who you are and the communities that you're passionate about.
Thank you.
I couldn't have said that any better. I've learned a lot, and I believe you all are outstanding. And I do believe that we were able to do what we were able to do because of you and the richness and the thoroughness of your input. So I echo the words of Dr. Williams, and obviously this is not it. We still have to write the final. So we will be or the final draft, sending that out to all of you. And this is our last scheduled meeting. So unless we see something different from you all, we'll do the rest of the stuff and work electronically, but we're open to your ideas because this is your product, right? It's our product. So we will continue to flesh it out and add some of these the additional things that you all have shared with us today. And I would just like to echo her words and just say it's really been an honor and a privilege to work with you on this outstanding and important work to our community.
It's not over yet.
That's right.
Not yet.
We got a lot to keep on doing.
Our work is never over.
True.
Yes. And Andrea, thank you so much for all of your organization skills of keeping us all on
Thank
point.
you, Andrea.
You're welcome.
Thank you.
I've really enjoyed it. Thank you all.
Thank you.
And
Thanks.
congratulations again. We saw your screen.
Oh, you weren't supposed to see that. I'm going to get in trouble for that one.
Stephen and Mark, does Stephen, you have anything? I thought you were saying something. No.
I was just saying thank you guys. It was a pleasure working with you all.
Likewise.
That was all.
Indeed.
Same here. The work isn't over. Thank you very much.
Yeah, I agree. The work isn't over. Stephen, there's more to come for you and I think, with some of the stuff you and I talked about.
I've got to put a plug.
We're best friends now, Mike.
I've got to put a plug in for something,
there's
guys.
no escaping us.
I'm with you.
Is that Andrea?
Yeah, just a plug in for something. We're supposed to limit what we say to you guys. I'm not supposed to be involved in the committee work, but I will say, now that you guys have a taste of what it's like to work on a board or commission, we have plenty of board and commission spots available through Urban County Government. Take a look through the list. I would love to see your faces involved in other things. And a lot of it relates to the same sorts of things we're talking about. You know, if you talk about neighborhood development or the Commission for Citizens for Residents with Disabilities, all of that, just links right into this work. So take a look at that board and commission work. Some of them are a little bit more intense than others, but I'd love to see your names come across to be appointed to some of those boards and commissions moving forward.
That has to be one of the most
you.
heartfelt public service announcements I've heard in a long time.
Thank you, Mike.
You're welcome.
All right.
All
you
right,
all.
it's been a pleasure.
Okay,
Yes,
thank you.
indeed. Have a great evening.
Bye
Thanks.
bye.
You
Take
too.
care,
Bye.
everyone.
Bye bye.
Thank you, Quinn. Appreciate you.
Thanks, guys. See you later.
All right, bye bye, Quinn.